Nursing and midwifery diabetes mellitus in pregnancy. Diabetes mellitus in pregnancy. This is a disorder characterized by relatively or absolute lack of insulin causing varying degrees of disruption of carbohydrate, protein, and fat metabolism leading to excessive glucose in blood. Insulin production may be low or it is made inactive by the pregnancy hormones. Pathophysiology. Insulin is a hormone for metabolism of carbohydrate/glucose. In its absence, glucose produced cannot enter cells to be utilized, leading to high blood sugar levels, hyperglycemia. When the kidney senses there is excess glucose in blood, it starts excreting the extra glucose, thus mother getting glucose in urine, glycosuria. The level at which the kidney starts to excrete glucose as excess is called renal threshold for glucose. For glucose to be excreted, it needs to be dissolved in water. A lot of water is extracted to the kidney for this purpose, and this leads to passing of a lot of urine polyuria. Due to fluids being withdrawn from tissues, dehydration occurs, leading to excessive thirst, and patient is likely to take plenty of fluids. Polydipsia. Glucose is needed for use in cells to produce energy since it is lost in urine. A state of hunger occurs and the patient develops excessive appetite. Polyphagia. When the body lacks energy from glucose, it uses an alternative source, i.e. fats. And nursing and midwifery diabetes mellitus in pregnancy. Black small square previous congenital abnormalities. Black small square babies with birth weight 4 and above or increasing birth weight. Black small square previous gestational diabetes. Black small square persistent glycosuria. Black small square age over 30 years due to reduced functioning of the pancreas. Black small square obesity. Cardinal signs. O polyuria. O polyphagia. O polydipsia. Classification of diabetes mellitus in pregnancy. General. Type 1 insulin dependent. Juvenile type. This is common in young adults. There may be destruction of the pancreas and so there is no insulin at all. This patient must be given insulin. Type 11 non-insulin dependent. Adult onset. Common in the elderly, there is reduced tissue response to insulin and later reduced functioning of the pancreas, so insulin levels are low. Patient may not use insulin. Nursing and midwifery diabetes mellitus in pregnancy. Classification of pregnant diabetics. Gestational DM. This is when a mother has abnormal carbohydrate tolerance with onset of first detected during the present pregnancy. This does not present until late in the second or during the third trimester. Women who are at risk may be identified when the history reveals one or more of the following: diabetes in a first-degree relative, parents or siblings, recurrent abortion, unexplained stillbirth, congenital abnormality, a baby whose birth weight was 4 or more at 40 weeks, previous gestational diabetes or impaired glucose tolerance, persistent glycosuria, age over 30, obesity, overt diabetes. This is when a woman has a normal glucose tolerance test, with or without symptoms, and a raised fasting blood glucose level may be detected in the first ANC visits. It may be pre-existing or detected for the first time during present pregnancy. Diagnosis can be presumptive if the fasting plasma glucose exceeds 105 mg/dl. Nursing and midwifery diabetes mellitus in pregnancy. Investigations. Fasting blood sugar (FBS) blood is taken off before patient eats anything. In DM, levels may be very low. Random blood sugar (RBS) blood is taken off in a time sugar levels will be higher than normal 80-120 mg/dl. Glucose tolerance test (GTT). The woman is asked to fast for a period of time, then the fasting blood glucose level is estimated. Then the woman is given a sweet drink which provides 75 mg glucose and blood taken off at regular intervals. Nursing and midwifery diabetes mellitus in pregnancy. 2 hours after ingestion of 75 mg of glucose, 145 mg. 3 hours after ingestion of 75 mg of glucose, 125 mg. Urinalysis, glycosuria and aciduria will be present. Ultrasound may reveal a big baby or congenital abnormalities. Effects of DM on pregnancy. These commonly occur if there is no control. Black small square fertility is reduced, and should conception occur, there is increased risk of spontaneous abortion and stillbirth. Black small square abortion due to changes in the body and the presence of polyhydramnios and the excess size of the fetus. Black small square intrauterine fetal death. Black small square macrosomia, very big baby due to excessive glucose from the mother cross the placenta into the baby, increasing its size, and birth trauma. Black small square more prone to urinary tract infections and greater susceptibility to candida albicans. Black small square perinatal mortality rate among infants of diabetic mothers are markedly increased. Black small square preeclampsia and eclampsia due to metabolic changes taking place in the High viscosity of blood. Black small square polyhydramnios. This may be severe and it is due to excessive urine excreted. Nursing and midwifery diabetes mellitus in pregnancy. A patient who was on oral anti-diabetic drugs has to shift to insulin since oral hypoglycemic drugs can cause congenital abnormalities. Analols. Diabetic controlled by diet may become dependent on insulin. A known diabetic dose of insulin has to be increased since some of the insulin is inactivated by pregnancy hormones. Effects on the fetus. Intrauterine death due to severe maternal ketosis. Congenital abnormalities since both the fetus and the mother share a high blood glucose level which leads to fetal hypoglycemia during the first trimester. Examples include defects in the kidney, heart, and neural tube. Defects. Intrauterine growth retardation, which is due to glycosylated hemoglobin. Hemoglobin bound to glucose that releases oxygen poorly to the fetus. Polycythemia, elevated red blood cells, which is a compensatory mechanism for lack of oxygen, but it develops into neonatal jaundice when the excess red blood cells are broken down, also exacerbated by the immature liver enzymes in the babies. Macrosomia, which is due to the fetus response to the high glucose level in circulation by producing more insulin, which increases the body fat and muscles. Causes of glycosuria in pregnancy. Lowered renal threshold for glucose due to increased glomerular filtration and impaired tubular reabsorption of glucose. This is common in pregnancy, however, blood sugar level is below 100 ml normal renal threshold. No treatment is required and the condition disappears after delivery. Increased glomerular filtration rate rises during pregnancy and glucose passes through the proximal convoluted tubule faster than it can be absorbed, leading to glucose leaking through and thus glycosuria. Glucose intolerance. There is acceleration of glucose absorption from the nursing and midwifery diabetes mellitus in pregnancy, which results in glycosuria in small but distinct group of cases, especially in later months. Human placental lactogen, a hormone produced by the placenta. Its function is to make glucose readily available for use by the fetus. This hormone antagonizes insulin, making it inactive, and in turn makes the levels of glucose to raise, thus glycosuria. Cortisones, present during pregnancy to prevent antibody-antigen reaction between mother and fetus. It inactivates insulin. Renal tubular damage. This interferes with glucose reabsorption and may be revealed for the first time during pregnancy. Note, glycosuria in pregnancy is not diagnostic of diabetes, nor it can be used as a monitor of diabetes in the pregnant woman. 2 episodes are regarded as an indication for glucose tolerance test. Glycosuria occurring anytime during pregnancy with a positive family history of diabetes or past history of having a baby weighing 4 or more should be similarly investigated. Management. Preconception counseling. Mother is explained that pregnancy worsens pre-existing DM. Tests are done to confirm there are no complications of DM, e.g., renal, cardiovascular, or retinal. Nursing and midwifery diabetes mellitus in pregnancy. To make arrangements for the care of the newborn. Antenatal care. Mother attends antenatal care in hospital and is seen more often, i.e., 4 weeks till 20 weeks, 2 weekly till 30 weeks, then weekly till admission. Mother is managed by physician and obstetrician. There may be need to admit this mother for some time for stabilization of the condition and education. Oral hypoglycemic agents are changed to insulin. Investigations are done whenever mother comes for antenatal. Black small square blood sugar should be done frequently, and glycosylated hemoglobin should be done at the end of first trimester and 3 monthly. Black small square urine testing for sugar, acetone, and albumin. Black small square urinalysis for any urinary tract infections. Black small square scan to diagnose congenital malformation and macrosomia or growth retardation. Black small square assess fetal well-being from 32 weeks onwards. Black small square taking of maternal weight. Black small square examination of the abdomen to detect polyhydramnios and for any diabetic complications. Health educate about susceptibility to UTI/vaginal infections. Nursing and midwifery diabetes mellitus in pregnancy. Minimize incidence of preeclampsia, polyhydramnios, and preterm labor. Proper planning for termination of pregnancy. Termination may be considered after 37 completed weeks, since majority of the intrauterine death occur in the last 2 weeks of pregnancy. If fetal life is in danger, it may be done as early as 34 weeks. Preparations for care of baby are made before an induction or cesarean section may be done. Depending on level of blood sugar, mother is put on soluble insulin, and oral hypoglycemic drugs are avoided due to their teratogenic effects. Management in labor. Induction may be done in the following Multipara with good obstetrical history. Prime gravida with no obstetrical abnormality. Congenital abnormality of fetus. Membranes may be ruptured and oxytocin put up. Caesarean section is done in the following. Elderly prime gravida. Mild gravida with bad obstetrical history. Diabetes mellitus, which has failed to be controlled. Obstetrical complications e.g. preeclampsia, polyhydramnios, malpresentation. Big baby. Nursing and midwifery diabetes mellitus in pregnancy. Young prime gravida or multigravida with no obstetric complications and diabetes. Is under control. First stage. All care given to a mother in first stage is given. IV. Dextrose is put up to provide energy. Blood glucose is controlled by this glucose and soluble insulin with hourly estimation of blood glucose. Analgesics are given to relieve pain. Epidural analgesic is preferred, hence strong. Sedatives and analgesics might depress the fetal respiratory center. Fetal condition is monitored closely and pediatrician is informed. Prepare to receive a premature asphyxiated baby. Second stage. Vacuum extraction may be done. Look out for shoulder dystocia. Third stage. Oxytocin is given and active management done. Postnatal care. Blood sugar is assessed after delivery before giving insulin. If it has reduced, mother resumes her pre-pregnancy treatment. Mother is counseled about breastfeeding. If she is a known diabetic, she should increase on her carbohydrate intake because of the increased nutritional demands. Insulin is given pre-prandial blood glucose estimation, i.e. pre-break, pre-lunch. Nursing and midwifery diabetes mellitus in pregnancy. Care of the baby. The K1 intramuscularly given at birth. Baby will need neonatal special care since it is premature and should be observed closely for at least 48 hours to detect and treat any complications. It is also at risk of hypoglycemia, therefore this care aims at detecting and treating possible complications, e.g. asphyxia, birth injuries, congenital abnormalities, hypoglycemia, severe jaundice, discharge. Mother is given advice like any other mother and she is advised on family planning. Complication. Black small square polyhydramnios. Black small square malpresentation. Black small square cord prolapse. Black small square uterine inertia. Black small square birth asphyxia. Nursing and midwifery diabetes mellitus in pregnancy. Black small square shoulder dystocia. Black small square placenta previous since placenta is likely to be large. Nursing care plan. Risk for altered nutrition, less than body requirements. Risk for altered nutrition, less than body requirements, at risk for an intake of nutrients that is insufficient to meet metabolic needs. Risk factors. Ability to utilize nutrients appropriately. Desired outcomes. Patient will verbalize understanding of individual treatment regimen and the need for frequent self-monitoring. Patient will maintain fasting serum blood glucose levels between 6 to -100 ng/dl and 1 hour postprandial of no higher than 140 ng/dl. Patient will gain at least 24-30 pounds prenatally or is appropriate for pre-pregnancy weight. Patient will be free of signs and symptoms of diabetic ketoacidosis, fruity scented breath, excessive thirst, frequent urination, weakness, confusion. Nursing interventions. Rationale. Assess and record dietary pattern and caloric intake using a 24-hour recall to help in evaluating clients' understanding and / or compliance to a strict dietary regimen. Assess understanding of the effect of stress on diabetes. Teach patient about stress management and relaxation measures. It is proven that stress can increase serum blood glucose levels, creating variations in insulin requirements. Weight decline every prenatal visit. Encourage the client to periodically monitor weight at home between visits. Weight gain serves as an indicator for determining caloric adjustments. Observe for the presence of nausea and vomiting, especially during the first trimester. Nursing and midwifery diabetes mellitus in pregnancy. Teach and demonstrate client to monitor sugar using a finger stick method. Insulin needs for the day can be adjusted based on periodic serum glucose readings. Note: values obtained by reflectance meters may be 10-15% lower/higher than plasma levels. Provide information regarding any required changes in diabetic management, e.g. use of human insulin only, changing from oral diabetic drugs to insulin, self-monitoring of serum blood glucose levels at least twice a day, e.g. before breakfast and before dinner, and reducing/changing time for ingesting carbohydrates. Metabolism and maternal/fetal needs. fluctuates during the gestation period, requiring close monitoring and adaptation. Research suggests antibodies against insulin may cross the placenta, causing inappropriate fetal weight, and the use of human insulin decreased the development of these antibodies, reducing carbohydrates to less than 40% of the calories ingested reduces the degree of a postprandial peak of hyperglycemia. Because pregnancy provides severe morning glucose intolerance, the first meal of the day should be small, with minimal carbohydrates. Provide information regarding the signs and symptoms and difference of hyperglycemia or hypoglycemia. Hypoglycemia may be more sudden or severe during the first trimester, owing to increased usage of glucose and glycogen by a client and developing fetus, as well as low levels of the insulin antagonist human placental lactogen, HPL. Ketoacidosis occurs more frequently during the second and third trimester because of the resistance to insulin and elevated HPL levels. Sustained or intermittent pulse of hyperglycemia re-mutagenic and teratogenic for the fetus in the first trimester may also cause fetal hyperinsulinemia, macrosomia, inhibition of lung maturity, cardiac dysrhythmia, neonatal hypoglycemia, and risk of permanent neurologic damage. Maternal effects of hyperglycemia can include hydrangeas, vaginal and urinary tract infections, hypertension, and spontaneous termination of pregnancy. Nursing and midwifery diabetes mellitus in pregnancy. The presence of ketones during the second trimester may reflect accelerated starvation, as the diminished effectiveness of insulin results in a catabolic state during fasting periods, e.g., skipping meals causing maternal metabolism of fat. Adjustment of insulin type, dosage, and / or frequency must be required. Instruct client to choose symptomatic hypoglycemia if it occurs, with an 8 osgaso. Milk and to repeat in 15 minutes if serum glucose levels remain below 70 mg/dl. Using plenty of simple carbohydrates to treat hypoglycemia causes serum glucose values to elevate. A combination of complex carbohydrates and protein maintains normoglycemia longer and helps maintain the stability of serum glucose throughout the day. Discuss the type of insulin, dosage, and schedule, e.g., usually 4 times/day, 730 m NPH 10 regular, 4 mph 6 regular. Division of insulin dosage considers basal internal needs and mealtime insulin to food ratio and allows more freedom in meal scheduling. The total daily dosage is based on gestational current maternal body weight and serum glucose levels. A mix of NPH and regular human insulin helps mimic the normal insulin release pattern of the pancreas, minimizing peak/valley effect of serum glucose level. Note, although some providers may choose to manage clients with GDM with oral hypoglycemic agents, insulin is still the drug of choice. Adjust diet or insulin regimen to meet individual needs. Prenatal metabolic needs change throughout the trimesters, and adjustment is determined by weight gain and laboratory test results. Insulin needs in the first trimester are 0.7 units/kg of body weight. Between 18 and 24 weeks of gestation, it increases to 0.8 units/kg at 34 weeks gestation, 0.9 units/kg and 1.0 units/kg by 36 weeks gestation. Monitor serum blood glucose levels fasting. Blood sugar, preprandial 1 and 2 HR. Postprandial on the first visit, then as indicated by client's condition. The incidence of fetal and newborn abnormalities is decreased when fasting blood sugar levels range between 60 and 100 mg/dl. Preprandial levels. Nursing and midwifery diabetes mellitus in pregnancy. Coordinate multi-specialty care conferences. Appropriate. Provides an opportunity to review the management of both pregnancy and diabetic condition and to plan for special needs during intrapartum and postpartum periods. Refer to a registered dietitian to individualize diet and counsel regarding dietary questions. Diet specific to the individual is necessary to maintain normal glycemia and to obtain desired weight gain. In-depth teaching promotes understanding of own needs and clarifies misconceptions, especially for a client with gestational diabetes. Prepare for hospitalization if diabetes is not controlled. Infant morbidity is linked to maternal hyperglycemia-induced fetal hyperinsulinemia. Risk for maternal injury Risk for injury, vulnerable for injury as a result of environmental conditions interacting with the individual's adaptive and defensive resources, which may compromise health. Risk factors: altered immune response, anemia, changes in diabetic control, tissue hypoxia, possibly evidenced by, not applicable, desired outcomes. Patient will be free of signs and symptoms of diabetic ketoacidosis, fruity scented breath, excessive thirst, frequent urination, weakness, confusion. Patient will remain normotensive. Patient will maintain normoglycemia. Nursing interventions. Rationale: assess the client for vaginal bleeding and abdominal tenderness. Vascular changes associated with diabetes place the client at risk for abruptio placenta. Determine nature of any vaginal discharge. If glycosuria is present, a client is more likely to develop manilial vulvovaginitis, which is nursing and midwifery diabetes mellitus in pregnancy. Contribute to premature labor. Assess and monitor for signs of edema. Because of vascular changes, the diabetic client is prone to excess fluid retention and PIH. The severity of the vascular changes prior to pregnancy influences the extent and time of onset of PIH. Determine fundal height check for edema of extremities and dyspnea. Hydramnios occurs in 6%-25% of pregnant diabetic clients. May be associated with an increased fetal contribution to amniotic fluid because hyperglycemia increases fetal urine output. Identify for episodes of hyperglycemia. Diet and or insulin regulation is necessary for normoglycemia, especially in second and third trimesters, when insulin requirements usually doubled. Identify for episodes of hypoglycemia. Hypoglycemic episodes occur most frequently in the first trimester owing to continuous fetal drain on serum glucose and amino acids, and 2. Low levels of HPL. In the presence of hypoglycemia, vomiting may lead to ketosis. Monitor for signs and symptoms of preterm labor. Hydramnios may predispose the client to early labor. Overdistension of the uterus caused by macrosomia. Note White's classification for diabetes. Assess the degree of diabetic control. Pedersen's criteria. Client classified as D, E, or F is a high risk for complications, as is a client with PBSB. Assist client in learning how monitoring of blood glucose to be done a minimum of 4 times/day. Allows greater accuracy than urine testing because the renal threshold for glucose is lowered during pregnancy. Facilitates tighter control of serum glucose levels. Request that client check urine for ketones daily. Ketonuria indicates the presence of a starvation state, which may negatively affect the developing fetus. Monitor the client closely if tocolytic drugs are used to arrest labor. Tocolytic drugs may increase serum blood glucose and insulin levels. Monitor serum glucose level each visit. Detects impending ketoacidosis. Helps determine times of day during which the client is prone to hypoglycemia. Monitor hematocrit and hemoglobin level on the initial visit, then during the second trimester, and at term. Anemia may be present in a client with vascular involvement. Nursing and midwifery diabetes mellitus in pregnancy. Monitor for total protein excretion, creatinine, clearance bun, and uric acid levels. Progressive vascular changes may impair renal function in clients with severe or long-standing diabetes. Obtain urinalysis and urine culture. Administer antibiotic as indicated. Helps prevent or treat pyelonephritis. Note: some antibiotics might be contraindicated because of the danger of teratogenic effects. Obtain culture of vaginal discharge if present. Candida vulvovaginitis can cause oral thrush in the newborn. Prepare client for ultrasonography at 8, 12, 18, 26, and 36 minutes 38 weeks of gestation as indicated. Determines fetal size using biparietal diameter, femur length, and estimated fetal weight. The client is at risk for CPD and dystocia due to macrosomia. Scheduled for ophthalmologic examination during the first trimester for all clients, and in second and third trimesters if clients are at class D, E, F. Owing to several vascular involvements, background retinopathy may progress during pregnancy. Laser coagulation therapy may improve the client's condition and reduce optic fibrosis. Start Roman 4 therapy with 5% dextrose. Administer fluticasone if a client is hospitalized with insulin shock and is unconscious. Follow with protein-containing foods/fluids, e.g. 15 grams of beans. Glucagon is a naturally occurring substance that acts on liver glycogen and converts it to glucose, which corrects hypoglycemic state. Note: hypertonic glucose D50 administered. Roman 4 may have negative effects on fetal brain tissue because of its hypertonic action. Protein helps sustain normal glycemia over a longer period. Risk for fetal injury. Risk for injury, vulnerable for injury as a result of environmental conditions interacting with the individual's adaptive and defensive resources, which may compromise health. Risk factors. Advertisements. Changes in circulation. Elevated maternal serum blood glucose levels, possibly evidenced by nursing and midwifery diabetes mellitus in pregnancy. Nursing interventions. Rationale. Determine White's classification for diabetes. Explain classification and significance to client/couple. Fetus is at less risk if White's classification is A, B, or C, the client with classification DDE, or F who develops kidney or stenotic problems, or PIH is at high risk. As a means of determining prognosis for perinatal outcome, White's classification has been used in conjunction with one evaluation of diabetic control or lack of control and two presence or absence of Pedersen's prognostically bad signs of pregnancy PBSB, which includes acidosis, mild/severe toxemia, and pyelonephritis. The National Diabetes Data Group classification, which includes diabetes mellitus, type I insulin-dependent, type Roman II non-insulin-dependent, impaired glucose tolerance, and gestational diabetes mellitus, has not yet had prognostic significance in predicting perinatal outcomes. Determine client's diabetic control before conception. Strict control normal HbA1c levels before conception helps reduce the risk of fetal mortality and congenital abnormalities. Monitor for signs of PIH edema, hypertension, proteinuria. About 12–13% of diabetic individuals develop hypertensive disorders owing to cardiovascular changes associated with diabetes. These disorders negatively affect placental perfusion and fetal status. Monitor fundal height each visit. Useful in identifying abnormal growth pattern, macrosomia or agar, small or large. Gestational age SGA/LGA. Assess fetal movement and fetal heart rate each visit as indicated. Encourage the client to periodically record fetal movements beginning about 18 weeks gestation, then daily from 34 weeks gestation on. Fetal movement and fetal heart rate may be negatively affected when placental insufficiency and maternal ketosis occur. Monitor urine for ketones. Note for fruity, where irreparable CNS damage or fetal death can occur as a result of maternal ketonemia, especially in the third trimester. Provide information about the possible effects of diabetes on fetal growth and development. Helps the client to make informed decisions about managing regimen and may increase cooperation. Provide information and reinforce procedure for home blood glucose monitoring and diabetic, decrease fetal or newborn mortality, and nursing and midwifery diabetes mellitus in pregnancy. Management. Anomalies are associated with optimal FBS levels between 70 to 96 mg/dl and 2HR. Postprandial glucose level of less than 120 mg/dl. Frequent monitoring is important to maintain this tight range and to reduce the incidence of fetal hypoglycemia or hyperglycemia. Discuss rationale/procedure for carrying out periodic oxytocin challenge test OCT or contraction stress test CST beginning at 32 weeks gestation, depending on the diagnosis of NIDM or GDM. CST assesses placental perfusion of oxygen and nutrients to the fetus. Positive results indicate placental insufficiency, in which case fetus may need to be delivered surgically. Review rationale and procedure for periodic NSEEG, weekly NSD after 30 weeks. Gestation, twice weekly NSD after 36 weeks. Gestation. Fetal activity and movement are good predictors of fetal wellness. Activity level decreases before alterations in FHR occur. Review rationale and procedure for amniocentesis using lecithin sphingomyelin ratio L/S ratio in the presence of phosphatidoglycerol PG. When there is impaired maternal/placental functioning before term, fetal maturity is a criterion used to determine whether survival is possible. Hyperinsulinemia inhibits and interferes with surfactant production, therefore. In the diabetic client, testing for the presence of PG is more accurate than using L/S ratio. Assess glycosylated albumin level at 24-28 weeks gestation, especially for a client in a high-risk category, history of macrosomic infant, previous GDM or positive family history of GDM. Follow with oral glucose tolerance test out if test results are positive. Serum test for glycosylated albumin reflects glycemia over several days and may gain acceptance as a screening tool in determining GDM because it does not involve potentially harmful glucose loading as does with OGD. Assess HbA1c every 2-4 weeks as indicated. Incidence of congenitally malformed infants is increased in women with high HbA1c level greater than 8.5% early in pregnancy or before conception. Note, HbA1c is not sensitive enough as a screening tool for GDM. Obtain sequential serum of 24HR urinary specimen for estriol levels after 30 weeks gestation. Although estriol levels are not used as often now, following levels may indicate decreased placental functioning, leading to a possibility of intrauterine growth restriction error and nursing and midwifery diabetes mellitus in pregnancy existed before pregnancy. Review periodic creatinine and clearance levels. There is a slight parallel between renal vascular damage and impaired uterine blood flow. Perform non-stress test NST and oxytocin. Challenge test OCT/contraction stress test. CSD as appropriate. Assesses fetal well-being and adequacy of placental perfusion. Prepare for ultrasonography at 8, 12, 18, 28, and 36-38 weeks gestation as indicated. Ultrasonography is useful in confirming gestation date and helps to evaluate intrauterine growth restriction error. Assist as necessary with biophysical profile. BPP assessment provides a score to assess fetal well-being/risk. The criteria include NSD results, fetal breathing, movements, amniotic fluid volume, fetal tone, and fetal body movements. For each criterion, met a score of 2 is given. A total score of 8-10 is reassuring. A score of 4-7 indicates a need for further evaluation and retesting, and a score of 0-3 is ominous. Assist with preparation for delivery of fetus, vaginally or surgically if test results indicate placental aging and insufficiency. Helps ensure positive outcome for the neonate. The incidence of stillbirths increases significantly with gestation more than 36 weeks. Macrosomia often causes dystocia with cephalopovic disproportion CPD. Deficient knowledge, absence or deficiency of cognitive information related to a specific topic may be related to lack of recall, lack of exposure to information, misinformation, unfamiliarity with information resources, possibly evidenced by questions, statement of misconception, inaccurate follow-through of instructions, development of preventable complications, nursing and midwifery diabetes mellitus in pregnancy. Patient will demonstrate proficiency in self-monitoring and insulin administration, nursing interventions, rationale. Assist clients and / couples' knowledge of the disease condition and treatment, including relationships between diet, exercise, stress, illness, and insulin requirements. When there is a clear understanding of both the disease condition and rationale for each, management helps the client and / couple make informed decisions. Teach the client to have a serum glucose monitoring at home using a glucometer, and then need to record readings, usually at least 2-4 times/day. Recording blood glucose measurements at home allowed the client to see the impact of her diet and exercise on serum blood glucose levels, and to closely control of sugar levels. Explain the difference between normal and abnormal weight gain during pregnancy. Facilitate home visits to check and monitor the weight. The normal total weight gain during the first trimester is 2.5-4.5 pounds, then 0.8-0.9 lb/week. After that, caloric restriction with resulting ketonemia may cause fetal damage and inhibit optimal protein utilization. Discuss the reasons why oral hypoglycemic agents should be avoided, even though they may have been used by the classic client to control diabetes before pregnancy. The oral hypoglycemia agent is not recommended to be taken during pregnancy because it crosses the placenta that potentially can harm the fetus. Provide information regarding the use and Action of insulin. Demonstrate on how to administer insulin by injection, nasal spray, or an insulin pump as indicated. Prenatal metabolic changes cause insulin requirement to change. In the first trimester, insulin requirements are lower, but they double or quadruple during the second and third trimester. Provide contact numbers for healthcare team members to give answers/enlighten the client with problems being dealt every day. Review hematocrit and hemoglobin levels. Provide dietary instructions on the importance of intake iron-rich foods. Anemia is a concern for diabetic clients because elevated glucose levels replace oxygen in the Hb molecule, which can result in reduced oxygen carrying capacity, causing more problems. Discuss how the client can recognize signs of infection. Caution the client not to self-medicate with vaginal creams available over the counter. Important to seek medical help early to avoid further complications. Choice of self-treatment may be an appropriate/mask infection. Provide information regarding the impact of pregnancy on the diabetic condition and future expectations. Sufficient knowledge can decrease the fear of the unknown, may increase the likelihood of participation, and may help reduce fetal/maternal complications. Assist client and/or family to learn glucagon administration. Instruct the client to follow with protein-rich foods such as 8 ounces of skim milk. Then recheck blood glucose level in 15 minutes. The use of glucagon and milk can increase the serum glucose level without the risk of rebound hyperglycemia. Glucagon is also useful during periods of morning sickness or vomiting when food intake is decreased and serum glucose. Nursing and midwifery diabetes mellitus in pregnancy.